Thank you very much, Mr. Chairman. What a great opportunity. These are very unusual days for all of us. And the form of this meeting is no acceptance. So with your permission, I will try online to speak a little bit about MitraClip current status, and I will, of course, touch the burning question of whether it's COAPT or mitral French, and we'll try and add a little bit on the current status and what we're doing these days in acute and subacute mitral insufficiency. First of all, we should be clear about the complexity of the mitral valve. Definitely, it is more complicated to treat than the aortic valve. We are all, or most of us, are doing TAVIs and very happy with the results, and actually with the smoothness and ease of the procedure once the diagnosis is made. Here in the mitral, first there is complexity in decision making, and then there is the complexity of treating the valve. It's not just an annulus, a fibrous annulus like the aorta, but there are the commissures, and there is the leaflets, which are much bigger and not that uniform like the aortic valve leaflets, and then the chordae, which we're not usually dealing with, papillary muscles, and the ventricle is a major player when you're treating mitral insufficiency. Now, there is the spectrum of mitral insufficiency. The degenerative mitral insufficiency, DMR, we're familiar with that. And this, with your permission, will be left aside. Now there is the secondary mitral insufficiency, either from LA, left atrial dysfunction, chronic AFib, hypertension, or what we usually see, what is more prevalent, secondary mitral insufficiency due to LV dysfunction. The annulus is dilated, and this can be either due to ischemic or non-ischemic dilated cardiomyopathy problem. When we're dealing with, and I'll make it somewhat crude, degenerative primary mitral insufficiency usually is left for valve surgery unless when there is an indication to treat, unless the patient is not a surgical candidate. Secondary functional MR, usually, as I mentioned, it's a disease of the left ventricle, and here we're focusing on medical therapy. There is a questionable role for surgery, and due to the high risk of surgery, and we're still left with the question whether surgery by itself affect survival. Very interesting and provocative work published at the New England 4 years ago showed that there is a very high recurrence of mitral insufficiency when the surgery is a repair surgery and not a replacement, and we're left with the question whether we should indeed, what's the role of repair in secondary mitral insufficiency. And as you can see here in the, this is 6 years ago, the guidelines for management of valvular heart disease, isolated surgery for secondary MR is class 2B with a level of evidence B. And we know the problem here is even if you treat well the valve, the risk of surgery is high, and there is the vicious cycle of mitral insufficiency, the pathophysiology, which is causing a very high mortality despite surgery. And then, because of the high risk of surgery, you are left with transcatheter valve repair. And here we're speaking mainly on the MitraClip. We have new devices now, the Pascal, but we're still focusing on what we're familiar with, and this is the MitraClip. Two sentinel trials, the MITRA-French and the COAPT, tried to give an answer for the efficacy, safety and efficacy of MitraClip in secondary mitral insufficiency. These are the inclusion criteria for the MITRA-French. I'll go fast here. About 300 patients, Primary outcome was all-cause mortality and unplanned hospitalization for heart failure at 1 year. And to make it short, the patients were much sicker than the patient that we've seen in the COAPT. And as you can see here, no major effect on the primary outcome, probability of freedom from an event. Patients that were treated medically or intervention had no major difference. And this actually, when this was published, some of us thought that this is a deathly strike on this whole procedure. And then came the COAPT very shortly after. Here, Greg Stone, Michael Mack, the principal investigator. And this is the largest trial, 610 patients randomized to either control standard of care. And the patients were the medical therapy here was much stricter, guideline-directed medical therapy or a MitraClip. And as you can see here, symptomatic functional MR, class 3 or more due to ischemic or non-ischemic, 1 hospitalization for heart failure in the 12 months preceding the procedure, or corrected BNP or NT-BNP, as you can see the values here. LVEF was 20 to 50%. I guess that most of us are familiar with the inclusion criteria, and the main issue here was that all-cause mortality was significantly reduced by therapy by MitraClip as compared to the guideline-directed medical therapy, reduction from 46% to 29%, significant NNT of 24 months of 6, which is quite striking finding. A very effective therapy in reducing all-cause mortality. So one should ask, what are the differences between these trials? One that shows no major benefit to the therapy, and another one that is clearly showing striking benefit in mortality, one that we're not seeing very often in any intervention. So there are several hypotheses on the major difference in these studies, and it's not just the size of trial, the fact that the MITRA-FR was about 50% smaller. First of all, the patients were much sicker in the MITRA-FR. As you can see here, the entry criteria, the EROA, effective regurgitant orifice area, in these patients was much more severe. In the COAPT, the patient was not end-stage patients, while in the MITRA-FR, some of the patients were end stage. As you can see here, the volume of the left ventricle and the diastole was much higher. And this is a major difference, 135 as compared to 100. And probably the patients were not as strictly medically treated like the patient in the COAPT. And yet, we're left at, there is a question regarding the skillfulness of the operators. Probably the patients, the doctors, the interventionalists of the COAPT were a bit more experienced, and yet we are left with somewhat unpleasant feeling in trying to explain the differences. But I think that the state of the art now is MitraClip. We're following mainly the COAPT. MitraClip is effective and should be considered in patients with secondary functional MR. And with your permission, I would like to spend the 5 last minutes of this talk speaking of the acute MR patients. And this is a new group that we're treating now. We're considering MitraClip or percutaneous mitral repair in patients with acute MR, such a patient with pulmonary edema and tethering, strict tethering of the mitral valve. And these patients usually are following acute MI, patients with akinesis of the inferior posterior wall. And we are seeing this severe tethering of the posterior leaflet. And we do see a lot of patients. Usually we used to treat these patients medically. And as you can see here, severe functional MR. These patients, until very not long time ago, were treated medically, either with a aortic balloon pump patients were very seldom considered for surgery, and we knew that these patients are quite doomed, that the prognosis is quite ill. The mechanism is quite simple, as we're familiar with. The akinesis of the patients with usually either circumflex occlusion or a very dominant right coronary, patients with inferior-posterior MI, tethering of the acute dilatation of the ventricle, tethering of the valve, and this vicious cycles is affecting the remodeling of the ventricle, causing additional dilatation, more annular dilatation, more MR, which begets more MR, and again, these patients are doomed. We know that the cardiac output is in acute MR is lower than the ones with chronic. Ejection fraction is getting even lower, and the diastolic pressure is high, and the left atrium compliance is not increased like in patients with chronic. The atrium cannot accommodate the additional volume, and therefore these patients are very critically ill. And here is an example of one of our patients, 70-year-old, 4 weeks after late arrival for inferolateral wall MI, presented in cardiogenic shock and on echo severe functional MR like the ones that you've seen here. And you see here the LA pressure, the V wave at the LA is extremely high, more than 40, it's about 40 to 50 millimeters of mercury. And the LA cannot accommodate this additional pressure and volume. So what's next? No matter how strict we are with medical therapy, it's very hard to treat these patients. Medical valve replacement by, unfortunately, we don't have a non-invasive way yet to treat this. So surgery usually is too complex and too deadly for these patients. And MitraClip is one of the only way that is available. And this is this patient following MitraClip. The insufficiency is significantly decreased, and the LA pressure, again here, as you can see here, is dropping to about 15 to 20 millimeters of mercury, and this can be definitely accommodated by the LA. This was published. We've published this MitraClip therapy in critically ill patients with severe functional MR, and a tip for this success of these procedures is giving in another paper here, the utilization of intra-aortic balloon pump in these patients. We try to unload the ventricle, trying to give some assistance to ourselves during the procedure, trying to reduce the volume of the ventricle even for a short while, and then we perform the procedure. And there is now a multi-center international registry of MitraClip in acute MR after MI, ran by my colleague Moni Shuvi. Patients here are included if they are treated with MitraClip for functional MR within the 90 days after MR, no evidence of structural valve damage. And these patients, I will try to make it simple here, are very symptomatic despite optimal and very extensive medical therapy, and therefore we should consider the MitraClip procedure as a salvage procedure. Until now, we have 20 procedures done in this registry, and as you can see here, quite a group of sick patients with diabetes, all of them, of course, with extensive ischemic heart disease. And as you can see here by the results, the MR dropped significantly, pulmonary artery pressure significantly dropped from about 60 to 40 on average, and the New York Heart Association class in all patients was 4 before. This is actually the inclusion criteria, have dropped to 1, mainly 2. Patients can live much longer and can almost resume normal life pattern after the procedure. So this salvage procedure in acute patient is a very helpful one. So in conclusion, MitraClip is an effective procedure, and in acute patient in recent MI or patients with acute ruptured cord and decompensated chronic heart failure patient with multi-organ failure, MitraClip can be very helpful in reducing morbidity and mortality. MitraClip is a safe intervention even in unstable patients. In hemodynamic unstable patients with acute and severe MR, MitraClip might be a valid option and should be considered as a therapeutic option in acute MR. But remember, early intervention is definitely essential. Evharisto, thank you very much for the invitation. Enjoy the meeting and hope to see you all in person soon. Thank you very much.